just want to have the panelists come down for our next session, Drs. Cavanaugh, Dr. Maher, Dr. Mashru. So we're going to talk about VTE prevention in orthopedic trauma. And Dr. Maher is a trauma surgeon. Dr. Mashru, trauma surgeon here at Temple. Dr. Mashru is an orthopedic trauma surgeon over at Cooper. And Garrett Cavanaugh is orthopedic trauma colleague up at Einstein. So, all right, so let's get started. Am I using the keyboard to advance slides? All right, great. Okay, so this is what we're going to talk about, different approaches to DVT prophylaxis in orthopedic trauma patients. We really don't have great protocols. Talk a little bit about some recent data and controversies, especially regarding aspirin and low molecular weight heparins, and just how different clinical scenarios might make us think differently. So here's one particular case. I guess you could say a typical polytrauma patient, perhaps. 31-year-old male, motorcycle accident. He's got a pulmonary contusion, femoral shaft fracture, renal laceration. Does actually have some hypertension in his past medical history at an early age. So I'm going to just go down the panel here. Rakesh, what are your concerns? And how do they guide management?
Just in terms of acute management of the patient?
Well, yeah, so we're just talking about VTE. What are your concerns here when you're thinking about preventing, a blood clot or dealing with bleeding?
Yeah, obviously there's going to be some bleeding in reference to the actual femur fracture itself, but obviously, I'd want a little bit more information in terms of what the renal laceration was. If it's a significant injury that's going to cause, the patient's in extremis, just from the renal laceration or the bleeding, then obviously we wouldn't necessarily put any prophylaxis right away. If the patient's going to the OR for the renal injury, post-operatively, then I guess we would consider doing it, but not initially.
Dr. Maher, what are your concerns regarding VTE prevention and something like this?
Yeah, I think the points brought up, whether the patient is hemodynamically normal or not normal, if the patient is undergoing large volume blood product resuscitation, you would consider withholding VTE prophylaxis. But I think looking at these images, though they are just spot films, there's nothing that I see that would make me not initiate VTE prophylaxis immediately. Okay, and
Garrett?
Yeah, the same that everyone has already gone over. It's the only reason to hold it at this point would be just if there is an element of severity to the renal lac, and if you get a lactate, and then we would defer to the ACS team as far as what they want to do as far as holding it.
Okay. Another question, it's not on the slide here, but we'll go backwards. Garrett, we'll start with you. Are you holding patients on VTE prophylaxis? Are you holding it before you take that patient to rod the femur morning of?
No.
Zoe?
No way.
No.
Okay, so we're not holding any. So meaning, nurse calls you and says the patient's about to get their Lovenox dose. Are you still okay going to the OR? You're like,
yeah,
don't hold it.
Yeah, for most cases, unless there's a very specific clinical scenario, we're usually operating through, Lovenox or not all, but most DVT.
Okay, so we're talking about orthopedic trauma surgery. So everybody's operating through whatever the prophylaxis is on the panel?
The only time that I will ask them to hold the morning dose is if I'm doing a large anterior open acetavium or open pelvis anteriorly, and their hemoglobin is already hovering at around 8 or below.
Okay.
That's the only time that I do.
Maybe just hands in the audience. Is anybody routinely holding prophylaxis before an orthotrauma case? Obviously you're a little perhaps biased now, but be honest. Okay. Okay, so holding it in the event that they need to do a peripheral block. Okay. What if your anesthesiology team is very bent on doing a spinal? Does that ever come into play with
Yeah,
the panel?
I mean, the biggest time that comes into play for us is for hip fractures, right? And so that is something that is a little bit of a different entity where if someone, I try to go over those cases as soon as they come in, which is tough, right? Because a lot of times I'll be the one to end up doing them, even if I wasn't on call the night before. But we've made a real big effort to coordinate with the trauma team as well as the anesthesia team. And if it's someone who is a candidate for a spinal, then we try to hold it and avoid the issue of having to hold Lovenox for about, it's usually 12 hours for Lovenox for spinal anesthesia. And so that we do try to anticipate, but we don't have a set protocol right now.
Okay, any other comments?
Yeah, I mean, same. I think usually to hold the DVT prophylaxis in the face of like a hip fracture, like Garrett was saying, I think usually that decision is made prior to even the patient, even that decision coming to us. So usually it's the anesthesia team who is, kind of dictating that, if you will. I can tell you, in our institution, we're doing less and less hip fractures under spinal for whatever reason. So usually, if there is a planned spinal anesthesia, then they'll usually want to wait to do a spinal if the patient's on Lovenox or something like that.
Yeah, I think there's a regain trial that we had been enrolling some patients, and then maybe he's going to be coming out that was looking at spinal versus general anesthesia for hip fractures with the presumption that they do better with spinals for post-op delirium, for instance. I don't know if that data is out yet, but with hip fractures is a problem. What I've found is that if you hold it, you better remember to restart it if the case gets canceled or bumped, or you hold it morning of, and then the patient's not really cleared, and then nobody remembers to restart the low molecular weight heparin or whatever they were supposed to be getting. What about, so from what you told me on the panel, what changes now? 67-year-old, fall downstairs, small, it's probably a large subdural, I think, but let's just say it's small. It's going to be non-operative. Intertrochanteric femur fracture, proximal humerus fracture. Patient has a history of a DVT in the past. They don't know where it was, just some kind of blood clot. You ask them if they had blood clots, they're like, yes. Zoe?
Yeah, I mean, this patient has a contraindication to immediate initiation of DVT prophylaxis. So, our institutional sort of pathway is holding VT prophylaxis until 48 hours after a stable CT head. I would say the literature may suggest that's even a little conservative, that you could actually go with 24 hours after a minor brain injury. But for this patient, we would also screen them for presence of active clot, given the history of DVT.
Rakesh, are you guys ever considering a filter for something like this? Or if not, then when would you?
Yeah, no, I mean, I think a filter is not, it's not unreasonable. I mean, I think, if we're trying to get this patient, to the OR sooner than later, then, our trauma team is actually pretty aggressive in terms of putting filters in. But I agree with the earlier comment, and we would defer to obviously our trauma or neurosurgical colleagues that, we wouldn't necessarily recommend DVT prophylaxis, right away, even in this clinical setting.
Garrett?
Yeah, the same. I mean, I would not be aggressive about doing it until the ACS team said that is something that is safe to do so. And, it's one of those issues where when it comes to a brain bleed, I kind of stay in my lane in their recommendations for it. And, the only thing is we just make sure that what I do is I write in my note, my recommendations, when and this is all right, this is what I recommend and for how long from an orthopedic standpoint, understanding that there's more issues that the patient has, right? And I do think that helps. That way you put that in your note that's in there every day, and everyone knows what, at least from an orthopedic standpoint, what the plan is to do, and also the duration moving forward, right? Like on discharge and stuff like that.
Let me ask another question. So same case, no subdural. Okay, so older patient, fall downstairs, she's got a bunch of fractures and history of some kind of blood clot. So are you treating this more aggressively from a VTE prevention standpoint, or are we just doing our standard protocol?
Yeah, I think obviously it would be relevant to know whether the patient was anticoagulated at the time of injury. I'm assuming based on what you're presenting, the answer is no, just carries a history of DVT.
Right.
More aggressive, no, but again, a patient with polytrauma who does not have a contraindication to initiation would get immediate VT prophylaxis. We have started to titrate Lovenox dosing for patients who come into the ICU based on anti-10A levels, which other people may be doing in the audience. And this is a patient who we would consider we would consider that in with no subdural.
So just to move along, just want to make it clear, I think VTE is a problem in hospitalized orthotrauma patients, although hopefully there's no disagreement there. I mean, these can really have significant morbidity. So I'll just step back now and say, there's really no generally accepted protocols, right? So how do you manage your patient who comes into your hospital who has a fracture and other trauma? What are you using? So Rakesh, what are they doing at Cooper? I'm assuming it's reasonably standardized, at least at your institution, but what are you giving inpatient, how long, and then what are you doing outpatient?
Yeah, so for our general surgery trauma service, unless if it's a non-orthopedic trauma patient.
So femur fracture and pulmonary contusion. So they're on the trauma service, but they have a fracture. So what are they getting inpatient?
So usually their protocol is Lovenox, 30 milligrams twice a day. Or,
Okay.
excuse me, 40 milligrams once a day. And if it's a higher BMI patient, they'll sometimes defer to 30 BID. And then if it's just like an isolated orthopedic fracture, then they'll usually just defer to us.
What are you doing outpatient? That patient goes home.
So it's interesting, outpatient, depending upon what was done for the patient in the hospital, sometimes we actually do convert them to aspirin. If it's an isolated lower extremity injury.
Femur fracture, yeah.
Yeah, so isolated lower extremity injury versus if it's a multi-system injury polytrauma patient, sometimes we do defer to low molecular weight heparin.
On the outpatient side. All right, so, okay.
But it's kind of a mixed bag. But we have been slowly getting away from low molecular weight heparin and using more aspirin in our protocols.
On the outpatient side.
On the outpatient side.
Okay. Zoe, do you guys ever do extended prophylaxis for, let's say you didn't have a fracture, a patient coming in with polytrauma. Is there any concern for do you send patients out? I know we do. I never asked you this.
Yeah, so for patients who have spinal cord injury, they get 12 weeks
Okay.
of prophylaxis, 40 daily. That's the only patient population that's a non-ortho trauma patient who gets extended prophylaxis.
Okay, and Garrett, what do you guys do inpatient, and then what are you doing outpatient?
Yeah, so we do Lovenox 30 milligrams BID for inpatients. And then on outpatient, that is the time where usually the orthopedic service will take over if it's a shared patient, right? And so when it comes to someone whose weight bearing is tolerated from a femur fracture, like in this situation, we usually discharge them out on aspirin. If they're going to a facility, a lot of times we just say, hey, continue the Lovenox, but I usually change it to 40 once a day once they're discharged. But it's like Mashru was saying, we don't have a set protocol for them other than we want to make sure that they're getting DVT prophylaxis for around 4 weeks. I usually do 4 weeks, and I haven't really seen much in the literature that benefits beyond 4. Everyone is like, is it 4 or is it 6 weeks? And I just stay with 4 because I think that it's easier from a discharge writing order standpoint and to just be consistent with it. But yeah, when their weight bearing is tolerated, a lot of times we have them go home on aspirin. So
yeah, we do Lovenox in-house and then 40 Lovenox Q-day for 30 days. One thing I've found, and I'm not saying that's definitely the right or only way to do it, one thing I've found is there's so many different services, stakeholders, different people. It's tough to sort of have a very nuanced way to manage this, I think. So I think what's worked for, we're dealing with internal medicine, a lot of different docs, that come in and out, that you can't just constantly kind of educate everybody. Trauma, there's all different types of people, there could be an emergency medicine resident writing the discharge orders, and then, our team, which is fairly, a little bit smaller and cohesive. So when we say just Lovenox for 30 days, it just becomes very, very simple, and the communication becomes very, very standardized. We just kind of do it for everybody, what it's worth. So I polled some of the Orthopedic Trauma Association community because I think it's a great question, and there's been a lot of discussion. I'll bring up some of the recent papers. Vanderbilt says, I asked them the same question I asked the panel. What are you using? What do you do outpatient, inpatient? Aspirin liberally in the hospital and on discharge. works just as well. Vanderbilt, Jersey City, they're doing aspirin. They're stratifying higher risk and treating them differently. And then they're also saying they'll sometimes place filters if they think that there's going to be, additional risks. At Bellevue, they're trying to move to aspirin, but saying, they're getting pushback from general surgery trauma. HSS, New York Presbyterian, brings up a good point. Says, using Lovenox, patients really hate the injections, and that's been studied. And I mean, you would think it's intuitive. Patients hate injections, but certainly there's some data to show that the patients certainly have a preference for PO medications. One thing they bring up is that if you test for DVTs, you're going to find them and you're going to get penalized. So the way to not get DVTs is not to test for it, which obviously is bad medicine. But the way CMS is set up, you look for DVTs, you find them, you get penalized. So they said there's a disconnect there. Cedars-Sinai saying they're using DOACs, they're doing aspirin for below knee, and they're also noting that they're kind of moving in the other direction as their trauma colleagues who are looking at, as Dr. Maher said, checking factor 10A levels. Atlanticare saying that they're trying to use more aspirin, and then some colleagues from other countries chiming in as well, using Lovenox, saying they don't really know about aspirin, how good it is, and then some of the other low middle income countries saying, look, I mean, it's just cheaper and readily available to use aspirin, seems to be working well. So that's just sort of a sampling, okay? And I think it goes to show we really don't have a good agreed upon protocol for orthopedic trauma patients. So I think one of the reasons I thought maybe this would be a timely panel, I came across this paper, maybe some of you did. This was in New England Journal a few months back. It was a lead article and got a lot of press, generated a lot of buzz. And it basically it's a randomized control trial, looked at multi-center, 12,000 patients, and really looked at aspirin 81 BID, versus low molecular weight heparin. And then after discharge, it was variable depending on what they used at their institution. But in-house, that's what it was. It was aspirin versus enoxaparin. And all comers, so this was pretty much all trauma patients, sick patients with multiple trauma, as well as just somebody with a femur fracture, but they all had to have a fracture, which you would think would increase their risk. So, and what they looked at is they looked at DVT, they looked at death from all causes, they looked at PE, and this is not the abstract, this is sort of like the visual summary New England Journal does for some of the high impact papers. And basically what they found was a non-inferiority study, and what they found was that aspirin was non-inferior to low molecular weight heparins when you look at death. The graph on the right, the bar graph, basically shows you did have higher rates of DVT. If you look at the data, it was actually all in below knee DVTs, actually, which you can argue the clinical relevance of that, but that's where they came from mostly. And bleeding complications, no change in death or pulmonary embolism. So, so their conclusion was that aspirin's not inferior to enoxaparin in trauma patients for VTE prevention. And it did generate a lot of press. Sometimes other journals will publish updates, in the literature, and being a lead article in New England Journal, it's going to generate some press. And I'd done a podcast interview with the lead author on it, and he'd done a bunch of others, and it's just something that people in our community have been talking about. So I'll step back a little bit. Just this can get a little tedious, so I'm going to try to go through this quickly. Just to say that there is a bunch of literature on this topic, looking at aspirin, and also looking at, are we not, if we're doing enoxaparin, are we not doing enough? Right, so here's a randomized control trial at a single site, I think Tampa, showing that in this study that actually, you can consider using rivaroxaban over Lovenox. Another study, this is from overseas, looking at actually Lovenox in-house and then discharge and aspirin versus rivaroxaban. This is aspirin versus rivaroxaban. This is 390 patients, so a relatively smaller study, and found that it was essentially equivalent. This is from the trauma literature, a little bit of a smaller study, retrospective review, and basically what they found was that you had to consider using titrating your factor 10A levels because you're underdosing a lot of patients. This is from JAMA Surgery 2018. This is a much larger study, but retrospective, 950 patients. And really what they found was that, yes, a lot of patients were underdosed, but in this particular study, they found that even when you did get appropriate levels, at least in this study, it didn't seem to change VTE rates. Another paper from the surgery literature, retrospective review, 204 patients, and they said that you had to really do an increased dosing strategy to decrease your rates of VTE, and although the numbers were not statistically significant. If you look at the AAST protocol, I don't expect you to be able to read all this, but this is relatively recent. And basically, what I want to show here is this, that ultimately at the very, very bottom, if you're going to dose with enoxaparin, whether it's 30 BID or 40 QD, that they recommend that you adjust per anti-10A levels, like Dr. Maher was talking about. So the bottom line, the whole bottom of this protocol basically says that you should be checking levels. Eastern Association, Surgery Trauma, this is a paper, looked at 698 patients, and basically said that there was a statistically significant reduction in VTE, but not with pulmonary embolism when you check levels. So this is an older paper. This is something that was probably one of the earlier studies looking at ICU patients and basically saying that, look, we're finding that if you do standard dosing, we're not getting therapeutic levels. So I keep bringing this up because I think it is interesting to see how we've been using enoxaparin for so long. There's now certainly a big push, and you saw it in the trauma protocols to consider factor 10A levels, and now you have another paper, pretty large study, showing that maybe you don't even need enoxaparin. Western Trauma Association, interestingly, in their protocol, which you can't read here, but what it says essentially is that if you're using low molecular weight heparin, you should consider checking levels. So AAST is pretty clear about it. Western Trauma Association says you should consider levels. So with that, maybe I'll just ask, go down the panel again. So are you checking factor 10A levels at Cooper?
No.
And have you, what about Einstein?
I mean, not that I'm aware of.
Not that you're aware of?
Unless one of our, Parker, do we? I don't think we do.
Yeah, we're not routinely checking them either. And that's something that is definitely worth bringing up with our trauma team. So.
And can I just ask in the audience, are you aware, I mean, some of you at other institutions, I don't know if you're aware or not, are you aware of, are you guys checking levels at any of your institution?
I think weight-based dosing is being done, but I don't think we're checking it. There's somebody quite obese.
Weight-based dosing for prophylaxis as opposed to therapeutic.
Yes.
Right, in an attempt to, achieve what's presumably better levels. Yeah, okay.
Can I just make a quick comment about this? So, we have been really surprised by the number of patients who on 30Q12 would be wildly underdosed, at least by anti-10A levels. Now, if you know the literature, you know that there is some debate about whether an anti-10A level is actually accurate. It certainly seems to be more accurate than, for instance, a PTT, even with full dose heparinization. But there's some debate about what the correct level is. But it's really surprising. You know, we're doing 40 twice a day dosing for low risk individuals admitted to the SICU, so no TBIs, no spinal cord injuries, no grade 4 or 5 solid organ injuries, not old people, not pregnant people. But so it's a small population, but of that population, nearly every patient gets started on 40Q12 and stays on 40Q12. And of the patients who have to be titrated, they're almost universally being titrated up to 50Q12.
Is there any correlation with the patient's weights?
So surprisingly, there's then actually not surprisingly, there's tons of heterogeneity, right? So some of these patients are very low, normal BMI muscular people who you would not consider based on BMI increasing their starting dose. So certainly there is data to support the adjustment for very high BMI patients up, and we're also doing that, but it's surprising. So I think there's going to be a lot more to come on this in-house, and I think ultimately we are going to find that all of our trauma centers are doing titratable Lovenox prophylaxis. I think that's where it's going. The other comment I just want to make real quickly about that New England Journal paper, which is a great paper. I mean, it's New England Journal. There are 12,000 patients. It's randomized. That's high-level data. The average ISS was 9, and that is a patient with a femur fracture only. So I personally, this patient that's being presented is in the ISS of 20 plus range, and that's only 10% of the patients who were looked at in that New England Journal study. And so I think for the polytrauma patient, what would be nice is to actually, and they didn't present this in that paper, they talked about the ISS breakdown, but they did not look at outcomes based on ISS, and I would be very curious to see the data about why they didn't present.
So I think some of the data, so what I was told, at least by Dr. O'Toole in our interview, was that they are looking at a sub-analysis data of the high-risk patients. And again, not to steal his thunder, and this is not published yet and still has to go through peer review and everything, but at least the sneak preview was that it did not seem to be a difference in the high-risk patients. Now, I don't remember exactly how we defined that. So let me ask then, I mean, should we be using aspirin in these patients in the hospital? Garrett?
I don't think so. No.
Why?
I mean,
And why not?
For one, I don't know. I mean, like that is a very comprehensive paper, right? And I get that. Just the one thing that I have an issue with is it is just one study and the data is good, but at the same time,
I think there are multiple studies. I mean, this is probably the largest study.
well, the Lovenox is much more something. It has a shorter half-life, right? And so in the hospital, I think that you have greater control, and if you have to take someone back or do something like that, aspirin stays in your system for a lot longer, right? Once it affects the platelets, then it's there for 5, 6, 7 days, right? It's like platelet turnover is like 10% per day.
I think bleeding complications, for what it's worth, were equivalent, if we're getting at that.
I just would I feel more comfortable about having patients on Lovenox in the hospital, and it's for that reason, honestly. It's for the adjustable amount of, okay, well, hold their Lovenox if you need to, if something happens, and then, but from a discharge standpoint, absolutely. And I think it's not just from a non-inferiority standpoint, but also, cost effectiveness,
Sure.
patient compliance, so that's a great thing. But at the end of the day, right now, I feel much more comfortable with
Dr. Maher,
Lovenox.
can we use aspirin?
No aspirin in-house.
Okay, why?
Why? Some of the reasons that were mentioned. I think that for me, the data is not strong enough, particularly for the polytrauma patient. I do think it's a viable option to consider for outpatient prophylaxis because we know that patients are more likely to be compliant.
I mean, a trauma patient with a femur fracture should be pretty high risk for DVT, although the ISS score may not add up very much. I mean, I don't know, intuitively, I think that is, I mean, not just intuitively, I mean, they have a long bone fracture that's going to impact their mobility. So, I mean, it is like a hip fracture, I mean, pretty high risk for a blood clot.
Right, and the data would say that patients who get aspirin only have a higher risk of DVT. So even though
2% versus 1%, mostly below knee.
I mean, I would say that what is clinically and statistically significant might be different, and I think a 1 percentage point increase, which is about where it was, may actually be clinically relevant.
Okay. So what matters for you, Rakesh, in this patient? Are you just worried about any DVT? Are you worried only about death from PE? Like, what's your goal?
Well, I mean, both matter, obviously, but
Yeah.
the more catastrophic one, obviously, is death from PE. I think, I don't think they're mutually exclusive, though. I think just because you're necessarily prophylaxing for one can help with the prevention of the outcome of the other. One comment I do want to just kind of echo what everyone else is saying. From all these studies we talked about, and hopefully people got the same impression. I don't think any of these studies are telling us what to do. I think they're showing us what we can do. And so I think all these protocols and these consortiums and all these things that we have going on, I think it's great. But I think it's going to be very difficult to kind of make a blanket statement and get a protocol that's going to fit and check all the boxes. So I think, in our practices, whether it's outpatient, inpatient, I think it's still based upon, each individual patient. I think it would be a mistake to come up with a protocol that just blankets everything.
Fair enough. All right, we're out of time.